Good evening and welcome to Prostate Cancer Research and the InfoPools webinar on overcoming challenges of informed decision-making in the treatment of prostate cancer. Just to show you the agenda before we actually introduce our speakers, we move to the next slide, please. Thank you. So the agenda outline, introductions, and first thing to let you know is that we're recording the webinar so that we can put it on the website so you can watch later or let your colleagues know who haven't been able to attend tonight. We're then going to meet Clem, our patient representative, who's going to talk about his experience of his diagnosis of prostate cancer and treatments. Debbie Victor, a specialist nurse from Cornwall, is going to talk about informed decision-making in metastatic prostate cancer, followed by Vinitha, who's going to talk about informed decision-making in the first treatments of prostate cancer. At the end, we have a Q&A. Please put your questions in the Q&A. You'll find a little icon at the bottom of your screen to put your questions in there, and we'll answer all your questions at the end, and we will finish at 7:30. Next slide, please. So when you shut down the webinar, a evaluation questionnaire will pop up, and please complete that. One of the questions is suggestions for future webinars. We'd be very grateful for your input on that, so that we can provide webinars that meet your needs. A certificate of attendance will be emailed to you, but you will need to tick the box on the evaluation form to get that. Also, at the end, there will be a QR code on the last slide. You'll be able to scan that and order resources from Susanna. Just handing over to Susanna now so she can introduce our panel.
Hello, good evening, everybody. I'm absolutely delighted to introduce our three speakers this evening. We've got Clem, who is our patient speaker from around the Surrey area, and he enjoys flight simulation. We'll hear a little bit more about that later. Clem will be covering how he made his decision, how he used the information he was given, what was good about the information that he was given, and what could have been better. We then followed with a presentation by Debbie, who is a uro-oncology nurse, specialist at the Royal Cornwall Hospitals. She is a non-medical prescriber and runs a nurse-led clinic for men with androgen deprivation tablets. In 2019, she was the BNJ Urology Nurse of the Year, and Debbie will be covering informed decision-making in metastatic prostate cancer. Then finally, we've got Vinitha. She is an MCS prostate cancer care nurse and Macmillan lead CNS, a clinical nurse specialist, from Cambridge University. Vinitha manages all the urology clinical nurse specialists in Cambridge. She leads a peer review and has responsibilities which include diagnostic pathway, developing patient support and education groups for empowering men with prostate cancer and equipping them for support for self-management. Vinitha will be covering the importance of informed decision-making at diagnosis of prostate cancer with favourable prognosis. So I'll hand over to Clem and Pauline.
So next slide, please. We're going to show you, first of all, the InfoPools shared decision-making video. You will find this on the website if you want to look at it again.
Hi, I'm Clem.
Hi, I'm Jack.
Hi, I'm Laura.
I was diagnosed with prostate cancer 6 years ago. When I was first diagnosed, I felt really disappointed. I kept thinking to myself, well, why have I got it?
I was 48 when I was diagnosed with prostate cancer. It was quite a shock. So after our first consultation, we left and we were both quite confused. So we got home and did some research.
When you've got no medical background, the information can be so confusing that you don't know which questions to ask.
Doing research beforehand helped us to have better conversations with our healthcare teams.
I would encourage you to read around the diagnosis that you've had. Be careful not to just type a generic search into a search engine on the internet. Please do use trusted sites such as the info pool and the booklets that perhaps you've been provided from your nurse specialist when you were initially diagnosed. These are there to give you the information that you need at a pace and in a place that's calmer and quieter for you.
Prostate cancer is twice more likely to affect an Afro-Caribbean man as their counterparts, so it's really important to have as much information as you can on your healthcare journey so you feel empowered to make decisions which are personal to you.
There is no such thing as a stupid question. Your priorities may be different to those of the person that you're talking to, and if it's something that's consuming your thoughts, it's important to ask it.
The info pool is a great resource to find out more about prostate cancer so that you can learn more about what options are available for you.
The info pool has information on clinical trials. Do ask your healthcare professional if you'd like to be involved, as you may be eligible.
You can also learn more about other people's experiences on the info pool. You can filter to find out relevant ones to you.
Visit www.theinfopool.co.uk for more information.
So you may recognise some of the stars of that cartoon, and we're going to introduce you to Clem now, our patient representative, who was one of the patients in the video. And of course, Debbie's going to speak later. She was the nurse specialist. Good evening, Clem.
Oh, good evening.
Hello, nice to meet you again.
And you again, Pauline.
Clem, can you tell me a little about you and your diagnosis of prostate cancer?
Yes, well, I'm now retired. I'm 60-something and living in Hampshire. It's close to Surrey, and married with 2 grown children who've now left the home, thankfully. What else is? Most of my career was actually in the Royal Air Force, serving as a communications technician. Also been involved in IT, and I worked partly for the NHS as well in the pathology transport department. So I've had quite a varied career, really. My hobbies, as mentioned, flight simulation, which I spend as much time as I can. I always say weather permitting, that's permitting I'm allowed to fly from my wife. And yes, as I say, married. I was diagnosed July 2017. After having a few symptoms, my wife kept telling me, you really need to go and get checked out because, it could be something more serious. As a man, a bit macho, don't want to go to the doctor, especially when it's private parts. And eventually, when I got to a stage where I felt I really needed to go to the doctor, I visited the doctor, and he referred me to the hospital for further investigations. I then had a biopsy, and I was told my PSA level was rather high. It was over 220. So following the biopsy, I was put on hormone therapy and then saw the oncologist for further treatment.
What treatment did you choose to have?
Well, the treatment was more being offered rather than a choice at the time. I was told basically that they didn't do operations. They wouldn't be doing an operation to remove the prostate, and that the treatment would be hormone therapy followed by radiotherapy, chemotherapy, and then radiotherapy. So we really didn't know any other treatments available. But I did find out, first of all, I've got to mention that my wife is an ex-nurse, so she knew all about medical terms, and it was all sort of, gobbledygook to me. We did come home and did the usual search on the internet to find out various treatments and things and what could happen and what symptoms would be. And there was so much information. It was just so confusing. For me, definitely, I found it really a struggle to weed through the information to find out exactly what was side effects, etc., that I could expect. So in those days, we didn't have the info pool, which would have been great for me because it's got such nice layout of different treatments, different side effects, etc., etc. So yes, going home after having been told you've got cancer, which was a massive shock, it really did knock me back a little bit. But my wife was there to sort of help me with questions that I would need to ask when we went back for follow-up meetings. And yeah, that helped me quite a bit, actually, having someone there to direct and comfort and just explain things.
Yeah. So I understand you entered into a clinical trial. So how did the decision to go into a clinical trial differ from your initial treatment decision?
Yeah, the clinical trial was offered very close to the start of my treatment, before actually the chemotherapy. And when I was, after the initial assessment about what I should be getting, i.e. the chemo, radiotherapy, etc., bearing in mind I was already on the hormone therapy, they introduced me to a trial. And I said, well, you know, what's it all about? What's the benefits, etc., as you would do? And we were given lots of information, quite a lot of information about the trial, and reassurance about that you didn't need to join the trial. You know, you're still going to get a good support, good treatment, and everything would be the same. However, being on the trial, you would have more monitoring, and therefore, you know, things could be picked up, as in my case, it was. And so having the decision to make to go on the trial was very helpful with the information they gave us, and knowing the benefits as well that you would get from being on the trial. You would be monitored, as I said, closely, even though it meant more trips to the hospital, but I believed it was going to be for my health benefits more than anything else.
Yeah. So you already mentioned that the info pool wasn't around when you had your diagnosis and you were making your decisions. How do you feel you would have used the info pool to make your treatment decisions or to join the clinical trials?
Yeah, I think the information about the side effects was one of the things that I was concerned more about. You know, people tell you that chemo, you do get bad days and good days, and radiotherapy, etc. You know, being in the prostate area, it could affect your bladder and that sort of thing. But hearing it from, you know, I say the horse's mouth, as they say, it just seems more reassuring, and to know that somebody else has gone through those experiences, and knowing that the side effects that I was having, that, you know, they weren't unique to me, and it would just help to sort of make me feel more to accept what I was going through, rather than not knowing what's coming around the corner and thinking, oh no, this is something different, I've got to go back and report it. Where if you know that, you know, you're going to get a lot of sickness, for instance, through chemotherapy. And one of the things was, like, you know, having, after the 3 sessions, I had 6 sessions of chemo. After the 3rd session, it just knocked me for 6. The first 2, I went back to work, would you believe, after the 2nd day. But on the 3rd one, it was just, I couldn't get up, I couldn't do anything. And just about everything was affected. So, you know, just hearing those sort of examples from other people who've gone through it, I think is very reassuring.
Thank you, Clem. We're going to talk to you again at the end when the questions come in. I'm sure people will have questions for you. So we'll talk again at the end. Thank you very much for sharing your experience.
Thank you.
Next slide, please. So I'm going to hand you over to Debbie Victor.
Hello, thank you for asking me to speak today. And yes, I am wearing something different than I was in the video. And no, my waist isn't quite as nice as my caricature. So I'm going to be talking today about overcoming the challenges in metastatic prostate cancer. So patients where we are looking to prolong their lives rather than cure them. So those of you that work in urology, I do apologise, some of this may not be relevant to you. However, because you're involved in the diagnosis of these patients, I think it's important that you have a little bit of an overview of what is ahead for the patients. Next slide, please. So what I'm going to talk about is who these patients are, how they come to us, what the metastatic prostate cancer pathway is, and how we as nurse specialists can help with decision making, including signposting to the right places. Next slide, please. So these patients, you'll know, you have your localized prostate cancer patients who are treated with curative intent, and hopefully that sorts it all out for them and they live happily ever after. But unfortunately, some of the patients that have curative intent treatment then go on to develop metastatic castrate sensitive prostate cancer. They can also develop non-metastatic castrate resistant prostate cancer. I won't be covering that today. And you can also have your patients that turn up with a very high PSA, undiagnosed, untreated prostate cancer, who come to us with disease visible, either widespread lymph node involvement, bone involvement, or visceral disease, so disease in other parts of their body. And that's your de novo metastatic castrate sensitive prostate cancer patients. There's also the metastatic castrate resistant prostate cancer patients, but I will only touch on those patients today because by the time they reach that point, they're very often well informed and well aware of what the pathway entails and are already doing their own research, including coming and asking about, can I have this drug that I read about? Next slide, please. So I've been a clinical nurse specialist for urological malignancies since, well, for 20 years. So a lot has changed in that time. Back when I started, you gave somebody that was on hormone manipulation, but their PSA was rising. You started them on bicalutamide and then referred them on to oncology when the bicalutamide stopped working. Back in so in the castrate sensitive setting, a lot happened in the 2015 when docetaxel was proven to be beneficial. That was your 6 weeks of treatment up front at the beginning, adding on some quite significant time. Then 2016, I remember being very excited that we had a second line chemotherapy that we could use in the castrate resistant setting. So we had more treatment that we could give to patients. And then in 2020, we had some tablet treatments that became available to us in the hormone sensitive setting, and we can thank COVID for that. I remember very clearly having to ring patients from clinic because the NHS, the government, had decided in March, April 2020 that we were no longer going to be able to give patients on chemotherapy that was not not curative intent. So I was ringing patients to tell them that we were stopping their treatment, which was very difficult. But then fairly quickly, NICE reacted to that and enabled us to be able to give the enzalutamide upfront in the hormone sensitive setting, which was a bit of a game changer. Apalutamide came along. Now olaparib is joining the party. I think we're, and then last year, spring last year, the triple therapy, darolutamide and docetaxel came along. So there's been a lot of changes, and there's bound to be more changes in the not too distant future, thanks to trials. So next slide, please. So hormone manipulation of the testosterone axis. So this is removing the testosterone. There's two ways of removing that. One is your LHRH agonist or your LHRH antagonist. Or actually, sorry, there's three, because let's not forget orchidectomy. That is still a nice recommended choice for men. And I don't think it's particularly widely discussed because of waiting list pressures. But if you've got a patient who's going to go and have a TURP, for example, because they've got really significant urinary symptoms, whilst they're under the influence of the anaesthetic and they're going to be on lifelong hormone manipulation, offering them the opportunity of having an orchidectomy, it should not be underestimated. It has less of the cardiovascular risks associated with it compared to long-term hormone manipulation. You then also have your testosterone receptor blockers. So bicalutamide on its own as a monotherapy is very out of fashion now, because that's got the highest cardiovascular risks. But one of the beauties of it was that it was something that was reversible. So that was a choice, and some people do still opt for that. And then now we've also got the novel anti-androgens, the ones that work, they're receptor blockers. And so they don't just, whereas the hormone manipulation such as Zoladex, Decapeptyl and Prostate, and then the antagonist, the Degarelix, and hopefully, well, in September, Relugolix is going in front of the NICE, and hopefully that will get approved because it's a tablet version. But we've got, they all stop the production of testosterone from the testicles, whereas the anti-androgens, they block the receptors on the cancer cells to any other type of androgen, testosterone that's produced in the body, which generally tends to come from the adrenal glands. So we block both. So you've got the hormone manipulation, and that will always be our first go-to treatment. Then you have your chemotherapy. As Clem discovered, he was given the docetaxel in the castrate-sensitive setting. And then in the castrate-resistant setting, we've got cabazitaxel as well. We can use steroids. As I said, the type of testosterone that's produced by the within the adrenal glands, if you switch off the adrenal gland, you also can affect the production of that testosterone that's driving the cancer. So it's not just a this will make you feel better steroid, it is a this is another treatment for your prostate cancer. And then we've now also got, this is in the castrate-resistant progressive stages. We've got the radium-223, which is useful for painful bone metastasis. That adds on average extra 3 months to life expectancy. PSMA lutetium was a type of radioisotope, a type of radiotherapy that was attached to the isotope that goes onto any tumor cells within the body that is taking up PSA. But unfortunately, it's incredibly expensive, and it does have some quite significant radiation protection issues. So currently is only available either within trials or privately. It's not been adapted or accepted by NICE as yet. We've now got the PARP inhibitors, and there's further studies looking at genetic mutations within prostate cancer and what we can use. And immunotherapy is very much still out on the fence, unfortunately. There were a couple of studies looking at immunotherapy combined with an anti-androgen, and this has been stopped because the patients that were not receiving the immunotherapy were better than those that were receiving the immunotherapy. And I think it's important to note that not all patients get all treatments. Some patients may be unsuitable for various reasons, but it's nice to know what's out there and what we can use. Next slide, please. So when we talk about benefits and risks for prostate cancer, what we need to consider is the benefits for the patient. So improved cancer control, improved patient choice, minimize any regrets that patient may have around what treatment they chose. But also we do have to think about the costs as well. Costs to the patient, how toxic is this treatment, what does it actually buy them for them struggling with that toxicity, how much time is it going to be, the traveling backwards and forwards to the hospital, maybe traveling for blood tests and various treatments and follow-up as well. We've got to think about those costs for the patient, as well as in pressure within the oncology department. I know that we shouldn't be thinking about that, but it's reality. We don't have finite resources, infinite resources, sorry. Our resources are finite. There's only so many people you can get on a chemotherapy chair in a day. There's so many nurses that can administer chemotherapy and other treatments. Some places may not have the nuclear medicine department that is required in order to be able to give radium-223. I know when we first started using it, we were sending patients an hour and a half up the road to receive a 10-minute injection. And then there's also financial pressures. As demonstrated with lutetium, it's such an incredibly expensive treatment, and the benefits that were that life expectancy that it brought just did not fit with how much it cost to give and how much it actually was. Next slide, please. So metastatic castrate sensitive, it's quite a busy slide and I apologize for that, but if you want to go away and look up the studies, enzalutamide, there was ARCHES and ENZAMET, and that demonstrated, what I'd like to draw your attention to is in that final box, 48 months of overall survival gain. Apalutamide, the Titan study, 24 months of overall survival gain. But what I will point out is apalutamide's not been around as long as enzalutamide, so their data is not as mature. So you have to take some of these factors with a small pinch of salt, because the data is still is evolving. The docetaxel given in the castrate sensitive setting, that's 6 cycles of treatment given 3 weekly. Again, overall survival of 17 to 22 months. It's quite a big hit of inconvenience for the patient having chemotherapy, but it gives that significant overall survival. And one of the things with docetaxel as opposed to enzalutamide, I guess you could argue, docetaxel, 6 treatments, 3 weekly, and then they're done. They're just back on the hormone manipulation, so they don't have long-lasting side effects from the treatment. Whereas the drugs like enzalutamide, apalutamide, abiraterone, they have to take every day until they stop working. So there's those sorts of things to consider when you're counselling a patient as to what their choices are. Abiraterone, overall survival 30 months. Again, in the castrate sensitive setting, the data is not as mature as it is with enzalutamide. If you can just click your button again, please, Pete. Unfortunately, abiraterone in the castrate sensitive setting is currently not funded by the NHS in England. It is funded in Wales and Scotland. So there is a little bit with, National Health Service, but each country has got its own health board and they make decisions as to what is available and what isn't. So next slide, please. And there's more. I couldn't fit this on that previous slide, but I just wanted to add it. So in the spring of last year, triplet therapy, they're calling it, docetaxel plus darolutamide alongside the hormone manipulation. Overall survival 30% less deaths at 40 months. That's quite huge, but this is predominantly in the patients with high volume, high risk disease. So patients that have got metastatic disease in the bone outside of the pelvis, or patients that have got visceral disease or high Gleason's grade, and any combination of that. And then also Stampede was a massive study, and it had so many different arms. It would be quite complex to even show a slide on it, but giving people with low volume metastatic disease radiotherapy treatments once a week for 6 weeks, again gives an overall survival advantage at 3 years of approximately, it's 8%. So it's not huge numbers, but it is an overall survival advantage. So all of these things, we as nurses, we need to be aware of what's out there, what the benefits are. So next slide, please. So just going back to when the pathway starts, Clem said he had a PSA of over 200. He had his biopsies taken. He would have had scans performed, and he started on the hormone manipulation. And that starting the hormones does start the clock. It's really important that we do get tissue samples, even in men with metastatic disease, if we're going to be consider future treatments, because the genetic changes will dictate what we can give to patients. So ideally not to start the hormones before the biopsies, unless there's spinal metastasis or risk of fracture. And then once the biopsies are done, get them started immediately, get the patient discussed at MDT and do that letter referring them to your oncology colleagues. Obviously, this is with a mindfulness that they've got to be fit enough to have additional treatments that may be available. But it's 12 weeks, so that is time to make a decision and to do a bit of reading and find out what is the appropriate treatment for that patient. Next slide, please. So let's just step back for a moment. First things first, these patients have just found out they've got incurable cancer. So they are going to be scrabbling around in the dark. They're likely to be emotional. They're likely to say to you, give me what you think I need. They could be searching for information. Their family will be searching for information. Their family will be advising them to stop eating sugar because that feeds cancer. They will be telling them to stop eating animal products because that encourages cancer to grow. They will be giving them advice about changing their lifestyle, perhaps drinking green tea and having tomatoes that have been cooked with onions for breakfast, lunch and tea. And if you throw a bit of turmeric on top of it, that's even better. So that is the family and the patient trying to take control and make sense of what is happening to them. But as I alluded to in the video, type prostate cancer into Google. And I did this when I was preparing these slides just to see what the numbers were that day. And it was 390 million results. How are you supposed to make sense of that? Next slide, please. So what we need to do is we need to break down the explanation of the treatment intent and the side effects. We need to speak to our patient, find out what is important to them. they may have a holiday to Australia booked that they've really been looking forward to, and it's in 2 months' time, and that they're making all of their decisions based around that. It's important that we make the conversation about the patient and not just about what we recommend. The way that I describe it to patients is that we are laying out our wares on our market stall and telling them what the benefits are, what the risks are, and ultimately the choice is theirs. A lot of patients will say, whatever you recommend, doctor, whatever you think is best, but it's important that the patient has a voice in what we're doing. Next slide, please. So I like this picture. The patient is at the center of everything that we do. The goals, not just the goals of the treatment, but the goals for the patient. The gains, that is what the survival advantage is, how easy it is for them to take or to receive. Are they going to be traveling backwards and forwards to the hospital? The gains for them. Are they going to be able to continue to go to work? Are they going to continue to be able to be themselves? And the pains, what are the side effects? But also not just with those pains, what the side effects are, but how we can help them to minimize those side effects. Next slide, please. So when patients are being asked to make decisions about treatment, I mean, some may come in and they're already, yep, give it to me. I want to start today, and that's fine. But I do like to give patients written information, and that might be a drug company glossy leaflet. It may be information that you've written locally. It may be information that you've downloaded from a website. But I like to go through that written information with the patient. I like to open up the booklets. We have a pack and it's a folder, and it's got lots of information about what patients do for themselves to keep themselves healthy, exercises, what resources are out there, including the info pool leaflet. We also ways of helping themselves. And I like to go through what's there so that it's not just, oh, they'll take it home and park it on the side and never look at it. I like to make sure that I make it relevant to them. So perhaps open a page and talk to them about, this is how you manage with hot flushes, or these are steps that you can take to help with your fatigue. Even highlight the relevance. I'm a bit of a so-and-so for folding down the pages that I think are particularly useful for the patients. So the pros and cons, those gains and pains, talk to them about that. The consultant's done their job, they've been in, they've spoken to the patient about what their intention is, but I think it's important that we also say to the patient, this is your choice. And if they are going to make a choice and think maybe they might not start the treatment that's just been prescribed, ask them not to fill the prescription until they've made up their mind, because once the prescription has left the pharmacy, it's got to be thrown away. And some of these treatments are £2,500–3,000 a month. So it's really important that they don't pick it up if they're not intending to take it. It's really important that we also discuss self-care and managing side effects, because these patients are going to have these side effects for a long time, regardless of what treatment they choose. So keeping themselves healthy and well, and giving them contact details of who they can speak to if they're having any worries or concerns are really useful. Some patients will come in. We've got one, he's a chef, and he always comes in and he asks, he's been reading and he's come with some really outlandish, can I have this treatment? Can I have this treatment? And his treatment that he's currently on, which was the triplet therapy, is working and still working, but he'll still, I want this, I want that, I want to go in this trial. But some treatments aren't yet approved on the NHS, which is why they're not available. Some patients, they may just be too low a performance status, too poor a performance status, or have multiple comorbidities that make them ineligible for the treatment that we can give. And don't forget, our whole remit should be to do no harm. So we need to bear that in mind. And sometimes the reason why they can't have the treatment could be because it's the wrong biology. So you can't give apalutamide to somebody who's not BRCA positive. Next slide, please. So signposting patients to the right kind of information that's online, especially patients that have got family that are interested in knowing what's going on and what their treatment choices may be. So the info pool is great, like Clem said. There's patients' lived stories. They can select who they want to hear from, so it makes it more relevant to them. And they've got comparator tables as well, so they can put what choice they may be thinking about, what treatment they may be thinking about, and they can read about the pros and cons of that treatment. The info pool is there. You've got Prostate Cancer UK, Cancer Research UK, NHS online has information, as does Macmillan Cancer Support. There's a whole wealth of information out there. We've got the My Sunrise app here in the Southwest. You can download it anywhere, but that has also got a prostate cancer specific pathway, including supportive measures, prehabilitation exercises, etc. You don't have to be unique to Cornwall. It's just that the photographs and things that are on the Cornwall one are of our department, which is the Sunrise department. But there's a whole wealth of information that we can direct patients to. They can sit down, discuss things with their patients, with their families, so their families know that it's not just the doctor's decision that the patient has been seeing, and the reason why perhaps that choice has been made. Next slide, please. So the info pool, I've spoken about it, this one of the reasons for this webinar is just to make you aware of what's available. Sorry, I'm not sure what my time left is, so I'm gabbling a bit, but there's a lot of information for all stages of prostate cancer available on there, and we can make sure that the patients have got access to all of those things. So I'm just being told I've got 5 minutes. So and I think this is my last, no, it's not my last slide. I've still got one more slide to go. So info pool is brilliant. It's prostate cancer specific. Prostate Cancer UK, brilliant, prostate cancer specific. Macmillan and Cancer Research UK tends to be cancer related and fairly generic rather than prostate cancer specific, but they're great resources. And most places have got a cancer support and information centre that they can refer their patients to. They've also got, you know, your CNS contact. Make contact with the CNS and support groups. Support groups are so important because as a healthcare professional, I know about these treatments. I can counsel you through the data and the side effects and the side effect management, but I've never had to take those tablets or have that treatment. So whilst I can read about it, I haven't got the lived experience. So never underestimate the power of introducing your patients to somebody else who's been there, got the t-shirt, and can help. And also quite often, if you're introducing them to another chap that's had it, then they've quite often got a significant other, and your patient's significant other can garner resources and support from the other significant other. So it's a win-win situation in that point. So my final slide. So take home messages from me, because I'm aware that I've been talking quite a lot and quite fast, because that's what I do apologize. So find out what your patient priorities are. Yes, they want to stay alive and not die of their cancer. That'll be a priority, but actually, is that everyone's priority? We need to find out what they want. I have got patients who decline treatment because their sex life is more important, or they they've had enough anyway, and they're just not bothered because they've got other health problems that they feel take priority. So find out what the patient priorities are. Make sure that you manage their expectations. It's really important in the metastatic setting that these patients know that we cannot cure it. Yes, a lot of men with metastatic prostate cancer die of something else, but a lot unfortunately do die of their cancer. And I think us as nurses, we can also, as specialist nurses, we know that trajectory, so we can fire those warning shots at a time that they're needed. If you've not listened to it, I can recommend The Waiting Room Revolution. It's brilliant. Give written information and make it relevant to them, open it, get them to look at it so that they don't just take it home and leave it on the side. Signpost patients to useful and trusted online resources. Infopool is great, but it's not for everyone. They may find something else, but obviously if they read the Daily Mail, tell them to check the validity of what's written in there on a trustworthy site. And there's always the option of reducing doses if they're not tolerating things too well, and stopping treatment and saying no to treatment. All of those are options. So I think that's me done. Next slide, please. So if there are any questions, please pop them in the chat, and there will be time for question and answer with us at the end. But it's my great pleasure now to introduce you to Vanitha so that she can do her talk.
Hello, thank you, Debbie. That's what good. That was very good. Thank you. Hello, everyone. And before I go ahead, thank you very much for PCR UK to organize this session for us and giving me an opportunity to share my knowledge and experience with all of you. So Debbie's spoken about the metastatic side of cancer and decision making. My talk is about the diagnosis of early prostate cancer. So the favorable prognosis prostate cancer, which is the early prostate cancer, which is our CPG 1 and 2 or grade group 1 and 2, or in olden days we used to say Gleason 6 and 3+4 7 prostate cancer. So that's what I'm going to discuss about. This is especially sharing what I do in practice and my experience in Cambridge, what we use, the resources available. So some of those may not be available everywhere, but it's for you to be aware of these things are available online as well. So next slide, please. Next slide, please. Yeah, so initially, why is it important to have an informed decision making in prostate cancer, especially early prostate cancer? So often, as you all know, prostate cancer, when it is early stage and it is confined to the prostate, there is multiple treatment options available. That is surgery, radiotherapy, brachytherapy, all the focal treatments like HIFU, cryo, CyberKnife, all those treatment, as well as not having a treatment is an option. So, and there is no evidence to say that one treatment is better than other. So we always often ask the patient to make a decision. And how are we going to help the patient to make those decisions? So to be able to make a high quality decision, you do need to be well informed. If you look at our own life, what decisions when we make, if it is to do with a mortgage or if it's buying things, you do look for all the information before you make that final decision, what you want to do. So why can't we help the patients to do that? So that's where this informed decision making is very important. And as Debbie mentioned, it is important to, consider the values and the preferences of patients as well. So, we have our own agenda to meet the target, to meet this and that, especially this FDS pathway, we have to make a decision and tick the boxes. But actually, this cancer is not going to grow all of a sudden and change things. Therefore, could we give that time to the patient? We do need to comply with the pathway, but is there a way to help the patients to make that decision and give them the time to explore all those options. So, considering what is important for them rather than important for us as healthcare professionals. And they also, it is important to inform patients their risk of prostate cancer versus risk from any other causes. So that is, give them an opportunity to understand and put things into perspective and then consider what is important for them as well. Next slide, please. So how do we inform patients? So we inform them through the patient information that can be, written information, video, any, signposting to websites and things like that. And also explaining, we all talk to patients. So when we explain how to explain these things, how do you explain the side effects of the treatment, and how you give them patients the tips in terms of considering the facts which affect them and things like that is important. And also explaining the prostate cancer risk versus other risk. What is other risk? We all have risk from dying from something else. So how does that, compare that with the prostate cancer risk itself? And then, we have decision aids and tools like InfoPool, Predict Prostate, CPG, all those kind of things available as well. And again, as Debbie said, support groups, buddy groups, Prostate Cancer UK does buddy group where patients can contact and talk to other people who had treatment. You may have a local support group run by a patient group or an organization. You can, signpost to patient, or you may have your own buddy group locally where, you have patients who had brachytherapy surgery. You can ask to talk to somebody else, or a patient on active surveillance, happy to talk to other patients. So it is important that we have that awareness and we explain or inform the patient about that, and giving them an opportunity to make the decision in terms of whether they want to explore it or not. Next slide, please. So what can we do as specialist nurses? So Macmillan Evidence Review in 2011 sort of concluded with, this is what we expect from specialist nurses role. So providing support at initial diagnosis, that's we all do, we all be present, and best practice guidelines, if you look at it, all the patients need to have a specialist nurse present at the time of diagnosis, as well as a point of contact where and when needed, and providing individual care and providing support with treatment decision making. How we do it, we all, there is different way of doing it. We all have our own way to do it as well. So that's where some of these tools helps to help us and help reducing variations, and signposting to the support services. So I think since 2011, there is a lot of support roles available in terms of, like cancer support team. We have support from cancer navigators. They do all the holistic need assessment and non-clinical support. So you may have those support available as well. So utilizing them, how we involve them at the early stage at the diagnosis. So we have in CUH, our support team, our prostate cancer navigator comes into clinic on the diagnosis clinic. And once I see the patient, Chris see the patient at the same time as well to introduce. And then there was follow-up calls and things like that he does as part of his service provision. And then the next one is readily available contact for patients. It will be ideal if we could all run a sort of telephone telephone service where you patient contact and real time you answer the call and reassure patients. But that is, we find it so difficult to practically manage a telephone service. So at CUH we provide a messaging system. So patient leave a message. We have an online system called My Chat where patients can contact us. but patients are informed this is a answer machine. You have to leave a message. We will contact you within 48 hours. So the expectations are managed that way to manage our own workload, especially with everything else going on. So that's next slide, please. Yeah. So in the specialist nurse's role, in the diagnosis clinic at Cambridge, we do the same as everyone else, support the patients and family at the time of diagnosis. We provide information and support for decision making, and we also do a decision making call and signposting patients to our East of England Cancer Alliance website called Knowing Your Options, Predict Prostate, and Info Pool. And point of contact for patient and family. So that is, what it was said on the Macmillan recommendations, as we all do, we do as well. Couple of extra steps to avoid returning back to clinic for decision making. We do telephone call as CNS to manage the service well. Next slide, please. So information provision and support for decision making. So some of this Debbie already mentioned. So we also have an information pack. So the information pack is made by we are lucky to have a volunteer who makes all the packs for us, and all the packs involves the treatment options. So we have like all options packs, which will have surgery, radiotherapy, brachytherapy, and radiotherapy information, sorry. And then Prostate Cancer UK information booklet. So we use this PC UK information after reviewing a few other booklet with our cancer patient partnership, because the feedback was that was easy to read, straightforward at the start of a diagnosis. So that's why we are using that. And again, as Debbie said, I don't give the pack just to patient. I go through them. So you need to read the room, when your consultant, so our practice in my Tuesday clinic, consultant goes in, the first patient, I'll get a chance to go in with him and I'll sit in the consultation. And then once he finishes, I'll take the patient to a different room where he then starts. So if I am from the start, it's, you almost understand where the patient's emotions and where they are with all this information. But when you are going in, you need to almost introduce and start knowing how much information patient retained from the consultation with the consultant. So I almost start asking, okay, do you want me to go over anything what the consultant said? And often what they will reflect on and say, okay, this is what said. Do you think that is right? Did I understood that well? So you can change it, or you can update them, or if there is any changes. But that's how I start, and then I go through the information. We all uses our communication skills, so I try to look at the non-verbal signals or cues to say, okay, if there is a facial expression changes, I would normally stop and go back and ask them. So explaining, understanding and making sure that what I'm saying is taken on board. So again, as Debbie said, I'll go through the information and go through the treatment options. And if we haven't discussed a treatment option, why we didn't do that. So I briefly explained like hormone only treatment option, why we didn't discuss that at this stage. Brachytherapy, why didn't we discuss that? It may be you have an enlarged prostate or you have bad LUTs. So brachytherapy may not be an option. So I would go through that as well, and the time frame and timeline for each treatment as well. And then in the pack, we have all the support information. So psychological support is provided by Maggie's locally. So we have a Maggie center near to our hospital, and we have a Cambridge Cancer Help Center as well. We have a prostate cancer patient support group and a specialist nurses contact and free prescription information depending on the age of the patient. So that is in the pack as well. Then we have the tools, that is the prostate cancer knowing your option website information, and the predict prostate information is in the pack as well. So the supported decision-making process is like, as I said, when the consultant finishes, I'll go through briefly on what is the diagnosis, their understanding from the previous discussion with the consultant. And also, depending on how patients are at that stage, majority of the time they had an MRI scan, biopsy, lot of patients expecting there is a diagnosis. So you have to see how they are taking in information. And some patients already done a lot of reading and research. And then you ask, you sort of plan your discussion according to their needs rather than you just going on about things. I changes according to the patient's needs, because I'm very aware that on the day we have broken a bad news, how much information, not overwhelming the patient, and how much information they may able to retain if you talk about all of the things. If it is patients who take on everything and asking me questions more about the prognosis and things like that, then I'll go through the steps that as mentioned here, I'll discuss more about the side effects of the treatment. I use the Cambridge Prognostic Group data to go through the risk and things like that with patient, and also talk about using Predict. Next slide, please. So what are the benefit of using decision-making tools? So there is multiple tools available. So as you may know, the info pool that's online. We have Predict Prostate, which is the prognostic tool we uses, and the Cambridge Prognostic Group tool that we uses as well. So Predict Prostate is an online website, so it will take time, and there is we have 20 minutes new patients appointment, so there is no way I can manage a full clinic using Predict. So I use a CPG, which I'll show you on the in the next slide or so how it look like. So it's easy to use. It's piece of paper laminated with the information. I take it into clinic and use it if needed, depending on how the situation on the day. It's easily understood, help patients to put things into perspective. So, when we are asking to make a decision, asking patient to make a decision, I believe that it is important that we support. So it's a collaborative process rather than we leaving patient to, make a decision. We empower them, we educate patients, provide information, and help them to make those decisions right for them. So InfoPool, I like the patient stories, how their lived experiences are there. So, when you see patients, when you work out, okay, these patients, when you provide the information, you try to understand their, the role of health literacy and how to make the sense of those information you giving. So you giving all this information, how patients can make a sense of those information. So that's some patients struggle. So InfoPool is a good example. There is examples and people lived experiences help patients a lot as well. Next slide, please. So at CUH, what we do is after the first appointment, patient will go home with all the information. They are advised to look on the websites of Knowing Your Options as well as Predict Prostate. And then is nurse-led phone call regarding decision making. So majority of the time, it's mainly going through their questions after they're reading the information and then rediscussing their overall risk from other causes versus prostate cancer. And then just making sure they understand the information. And majority of the time, they may have few questions and they looked up the system and they would probably tell me, oh, I think I would want to go for this. There is some patients, sort of struggle to make the decision. So if they are struggling to make a decision, I would, I would be asking them some questions. So like, a bit of a coaching style. So you would, go through, okay, what is it you finding difficult? So consider, how you feel about if, taking a worst case scenario of surgery, the side effects, there is a 5% risk you may be incontinent long term. So if you have to wear a pad long term, how do you feel about this? Is that going to stop you doing anything? If so, are you able to manage and accept this? If the question's answer is no, I'll be struggling. Do you think, is it worth going through that way? And then you go to the next one. So I would say to patient, read the information, sort of bullet point the side effects and ask these questions for each of that, and then see how you feel about. And if you have a lot of no's, then maybe that may not be the right thing to do. So that's how I sort of start my discussion if patients are struggling to make a decision. And I also check at that point if they have looked into the PREDICT or info pool and things like that. And after all that discussion, if they are still struggling, I'll arrange an appointment with the treatment team at that point. Next slide, please. So this is how the CPG, the information available. So if you, for example, if I have a patient 65 year, just normal, that age group, we have a lot of patients. So if they have an early prostate cancer, which is a Gleason 6 grade group 1, and their PSA is less than 10, and their clinical stage is T1 to T2, they fall into Cambridge prognostic group 1. So their 10-year risk of dying from prostate cancer without any radical treatment is about 1 to 4.5%. And if you have a treatment with the radical treatment, the risk is reduced to 1 to 1.5%. And then if you look at the, the bit down there, it's talking about 10-year risk of dying from other causes. So if you are a man in 60 to 69, there is about 9 to 12.5% risk of dying from other causes. So when I'm discussing with patient, I would say, this is the risk. And all of a sudden you will, so you can see, okay, they will start relaxing back a little bit and then start thinking to themselves. So some patients would say, okay, are you saying that I need to be more careful crossing the road than this prostate cancer itself catching me? So, they all of a sudden, it made sense to them. So that's how I use it, just making sense of the information I'm giving. And also you could ask them, okay, your risk of dying from prostate cancer without treatment in next 10 years is about 5%. And 10-year risk of dying from something else is this much. But your benefit of having treatment about 2 to 3%. So what are you paying to gain that 2 to 3%? It is likely your quality of life, how that affects you. So how do you feel about that? So when you ask these questions, patients start thinking about it in a way that how that will be personalized for them. So that will help them to make that decision. So that's my experience. Thank you. Next slide, please. So the PREDICT Prostate is another tool that is bit more longer information. You have 15 years of evidence. So you can compare 15 years of prognosis with and without treatment, and the side effects of each treatment as well. So it is time consuming. You can prep, you can prep the clinic and print out. We use this, we predict in MDT. So when we prep the MDT, we use this predict to get their benefit and risk, so that it helps in MDT decision making. And it works better for patients if they are, using at home, taking their time to read and understand. But you need to make sure that we give all the details. You need to put your PSA, T-stage, BRCA test information, biopsy details, etc. So you need to make sure that you give that information. For us, we provide that information on our clinic letter, and it's need a bit of explanation. It's a good, it's a bit visual. You can change into the wording, text, or charts and things like that. Next slide, please. So it's, again, as Debbie said, use of InfoPool. So InfoPool, it covers from start of the pathway, where from the PSA until the metastatic prostate cancer end of life care. So sometimes patients sort of look through all of it and then worried about, oh, is this going to happen to me? So just need to warn them when they are accessing that it's all the way through. It doesn't mean that you will go through that. So that's important. There is animations and graphics. Patient stories is the one that I like, and a couple of patients said that was really helpful. And there is all other support like trial finders and visual interpretation for patients are available as well. So that is a good tool to use as well to signpost patients. Next slide, please. And we have done some audit to see, using this decision tool, is it helpful? So we did it pre and post using the tool. So our treatment rate was, looked at in an audit. So our treatment rates 2016 and 2019, the low-risk prostate cancer, over treatment of early prostate cancer reduced from 23% to 4%, and under treatment, which is not treating or not providing a curative treatment like hormone only for a Gleason 9 prostate cancer. So under treatment rate of high risk prostate cancer reduced from 27% to 16%. Next slide, please. And then what we did is we compared this with the National Prostate Cancer Audit. So our overtreatment rate for early prostate cancer for CPG1 is 4%, comparing to the national data of 11%. And same for undertreatment, 16% for us and 24% nationally. Next slide, please. This is my conclusion. So using prognostic tool and InfoPool websites that helps patients to reduce anxiety and empower them to make the decision and avoid delay in making decision. It helped me, when I never used these tools, just avoiding the repetition, going around and talking the same thing. So it will help in terms of appointment time and things like that. But I do still have some patients take long time that need that time, which I can provide. Reduce treatment regression. So that is the main thing. So if you are regretting about the treatment, then it will affect your recovery, affect your mental health, all those, then the quality of life. So it is important. So this using the informed decision making will reduce the treatment regression because patients are making the decision which is right for them. And then if you are not having the treatment, it improves adherence to surveillance as well. Thank you. I think that's my last slide. Next slide, please. Yeah, thank you very much for everyone listening to me. So if you have any questions, put it on the chat. I think we may have a few questions, isn't it, Pauline?
We have a few questions. Thank you, Vinitha. Excuse me. Thank you, Vinitha, Debbie and Clem. Absolutely brilliant presentations. I've really enjoyed them. So we do have a few questions in the chat. Just to let you know, you can still put questions in the chat while we're talking. Please do. And we've got a few here. Susanna, have you got the first question?
Yes, Clem. Hello, Clem there.
Hello, yes.
I've got a question for you.
Good.
Would you say that you did not have treatment options, but were told the treatment you required, that the Infopool was more beneficial from other patients' experience perspective?
Right, that's quite a long question. Yeah, I think basically not having the option and being told what treatment I was going to have meant that I didn't have a choice to decide, and having the Infopool would have given me that extra information to say, right, well, you're going to have radiotherapy, so this is what you can expect from the radiotherapy. And also for my partner, stroke, my wife, or anyone going through that would have their family, like you said, searching on the internet, 900 and odd million. We did the same searches, and it was overwhelming, the amount of information that came back. So yeah, it's not just for the patient, I think, the Infopool, it's also important for your families as well.
Thank you, Clem. Vinitha, I've got a question for you. We've all got patients who need that extra time to make a decision. And I've actually met patients who weren't my patients. They came to a support group who a year later still hadn't made a decision. And we have the cancer trackers on our backs, beating us with the target date. Can you start this patient on active surveillance, or can you start them on hormones? How do you, as a specialist nurse, manage those two competing, very important decisions that have to be made there?
Yes, I'm hoping that my cancer tracker listening to what I do is I will tell the patients that I will be contacting to make sure I'm supporting you. This is because we have this kind of target to meet. However, clinically, this does not affect you. The cancer itself, especially early prostate cancer, we are recommending active surveillance. So why do we need to, sort of rush them? So the good thing that the cancer waiting target change, like CPG 1 and 2, if as soon as we tell the patient, we can tick off their pathway. So I manage that way. When it comes to CPG 3, they still have open pathway, but then the patients are not given the active surveillance as an option, or they don't have that option, so they do tend to make the decision. And if there is patient struggling, I would tell the trackers, I need to give the patient that time. So you have 75% target you made, but the other 15 or 30% you have those those variations there. So that's how I manage it.
Yes, it's quite hard, isn't it?
It is, yeah.
Susanna, have you got the next question?
Yes, I've got a question for Debbie. It says, Debbie, 54-year-old patient with bone mets on NM bone scan. Do I biopsy first before bioclimide, or can I start with bioclimide before I biopsy?
Thank you, Susanna. So yeah, that's a good question. Our recommendation would be that as long as you've not got a 6-week waiting list for the biopsy, and there's not been highlighted that there's a fracture risk. So as long as your patient's not got bone pain as one of their presenting factors, or the person who's reported the scan hasn't said there's a fracture risk in the pelvis, we had one who had a fracture risk in his arm, then you can get away with not starting the hormone manipulation, so that you get that Gleason score. Because even with bicalutamide, if you start the hormone manipulation, the cancer can start to regress. And whilst they can tell you if they've got prostate cancer or not, they might not be able to tell you a Gleason score because it's already started being treated. Yeah, as long as they're not symptomatic from pain, or you've not got a very long waiting list to get the biopsy done, I would say wait. And like the blue touch paper on the day they attend for their biopsy with regard to starting the bicalutamide.
Yeah. That's what we would do as well. Yeah. And Clem, can I ask? I know you didn't really have any choice about what treatment to have at the start, and you did have a choice about going into a clinical trial or not. Looking back, do you have any regrets about the time of being started on your treatment?
No, none at all. I think really my process was very, very quick. Within about a month, I'd had CT scan, MRI scans, biopsy, and I'd had half a dozen appointments at the hospital or so. So, you know, I was not fast-tracked, but it seemed to happen very, very quickly. So, and also going on the trial, it was really, you know, information, any questions, come back again and go through what the process of the trial was. So yeah, I had no regrets at all, either the trial or having the treatment that was given. In fact, can I just say one thing on the trial? It's part of the trial is regular monitoring, and that's blood test, questionnaires, etc. And every 3 months I'd have a blood test and they'd check for loads of different things, and one of the things was hemoglobin, and mine started to fall, and the oncologist said, yes, well, you can take iron tablets, etc. That didn't help, and after about 3 test results, he then said, well, we must do something, you know, check this further. An investigation found out that I had a tumor in my colon, which most probably wouldn't have been picked up if I wasn't on the trial, because, you know, that extra monitoring wouldn't have been there. So yeah, I have that to thank the, you know, it was Stampede trial for. So yes, that possibly saved my life, because I most probably wouldn't have known, and I wouldn't have gone to the doctor, because, you know, you think, oh, it's just part of the treatment. So yeah, extremely grateful.
I think actually, if you'd been under the care of many of us general urologists, we might have assumed that your anemia was part of your hormone treatment side effects as well, and might have taken a bit of time to arrange the appropriate investigations. Yes,
that's quite true. Yeah,
fortuitous. Yeah. Susanna, have you another question?
Yeah, sorry, I couldn't unmute myself. Another question for Debbie. You mentioned that you had a patient on triple therapy. What are the points that you and your patients talk through when deciding between doublet and triplet therapy? And do you counsel patients towards one or the other? And how do you do this?
Now I have to say that very often thoughts around the triplet therapy have happened between the consultant, the registrar, maybe the nurse has thrown her 2 penneth. I can't let them have those conversations without me having a say. I'm just, you know, I've got an opinion on everything. But I think when it comes to the patient, if we're considering triple therapy, then we will counsel them about what the aims of the triple therapy and what it entails, including that 6 cycles of docetaxel chemotherapy. But we will also talk to them about single agent treatment, and then go through the benefits, the risks, what they're likely to expect. Get them to sign if they want to. They can take some information away and come back, because don't forget, you've got 12 weeks from them starting the hormone manipulation. So it's important that they take that time to decide whether it's right for them or not. And then we can bring them back, get them to sign their consent form. Some people are ready to sign there and then, but even then we say, just because you've signed your consent, you've got a cool-off period. Go away, do some reading, think about it, ask us some questions. You have a right to withdraw consent at any time. And so the patients don't start the darolutamide, so it's docetaxel and darolutamide. They don't start the darolutamide until the day they attend for their first chemotherapy. Usually, I have noticed there's been a couple that have slipped through the net, but those are the ones that are absolutely adamant that's what they want. That use that 12-week lead-in period to make sure that the patient has no regrets.
Thank you. I've got a question for Vinitha. Pauline, is that right? Thank you very much, Debbie. So Vinitha, hi, it's a lady from Cornwall. I won't confidentiality. What's the patient satisfaction with the use of CPG tool, predict tool, etc., in helping make a decision? And has this been audited or compared to not using a tool?
Yes, so not completely taken. So I'm currently doing the using, the satisfaction from using the tool, so which I started in December. So I have some data not published yet, but I have done a feedback or audit as part of my master's project without any of these tools. So I have that, and now I'm currently doing a feedback, so which is actually a patient experience survey to look at their experience using the tools. And then we have in NHS England, I don't know you all aware that we're looking into the treatment variations. So we are doing an audit as well to compare if we are saying, if the variations and the satisfaction matches. So yes, we are in the process of doing that. I have already have the data and then I'll be having the post data by June.
Good to hear. I look forward to seeing that.
Yeah.
Debbie, sorry, I've gone and lost my question. I'll be 2 seconds while I find it.
I was just reading it. Is that the one from the non-clinical person who works in community?
Yes.
So a non-clinical person based in a community in primary care in Kent asked the question about the benefits, because you can give the patients time, and absolutely fully support non-clinical people supporting patients, either in primary care or secondary care. Where I work, we've got cancer support workers. They are used to do the holistic needs assessment, like Vinitha was saying. They can be used to track patients through the system. We get them to we deliver a healthy on hormones class to men. It's a 2-hour session, and we've got one of our band 4 support workers helping with that. And we also use our non-clinical band 4 workers to man the phones and do the remote supported self-management of the men that have had treatment that no longer need to be completely engaged with the clinical team, but still need a degree of monitoring or support. So those band 4 workers will signpost patients, listen to their concerns, and only if they are unable to deal with those concerns, they will then let the clinical nurse specialist know, so that they can then go back and deal with it. So yeah, absolutely, fully support widening the net of support that these men can have.
Thank you very much. Well, thank you to our speakers, Debbie, Vinitha and Clem. Thank you for giving your time tonight to come and talk to us. Clem, there's been a comment in the questions how much this questioner has appreciated your talk in particular tonight.
Thank you very much. Thank you.
Just to let you know that our next webinar will be on June the 11th. The topic is going to be clinical trials for non-research nurses. So just to give people some information about what's involved in a clinical trial and the preparation of patients. We hope we see you there. Just to remind you that the webinar will be on the InfoPool website in about a month's time, so middle of March, for you to catch up. Well, signpost colleagues too. Please fill in the evaluation as you shut down, and also give any suggestions that you have for any future webinars. We would really appreciate that. And just a reminder that you need to tick that you want a certificate if you do want a certificate, and it will be emailed to you. So thank you very much and good night.
Bye.